Barbara mentioned, we're at the cusp of the collision of three great revolutions in various types of data. The scalable health data that we find in many places, including health systems and other related entities. That includes demographic data, geospatial data. The revolution in the ability to measure omics, genetics, proteomics, metabolomics at a scale never before, unprecedented, for fractions of a penny to get a variant measured. You get hundreds of thousands of them measured for a few dollars. And then the revolution in computing and in capability and capacity. So I'm going to highlight a few themes today. The first, I'm going to share with you what an amazing data resource is at the VA. The second are just some of the structural components of this amazing collaboration. And then the importance of these types of collaborations, the types of collaborations between the VA and our affiliates, academic affiliates throughout the country, and how that has allowed us to elevate the quality of what we do. Of course, always remembering that it's all in support of our core mission at the VA to improve the health of veterans, and by extension, to when possible, improve the health of all Americans. So, just a couple of disclosures. You'll hear from many VA investigators today, both with paid appointments and without compensation appointments. And the views expressed today do not represent the VA or the U.S. government. They represent the speakers. We're going to be talking about a research program and portfolio that's supported by the VA, the Office of Research and Development, in particular, primarily by the Quantum Studies program, which is nested in a very large research infrastructure. It's a close collaboration between the causal methods core and the activities that we call Maverick at VA-CAUSAL. Here we go. So you heard Barbara talk about the learning healthcare system and how central data is to the learning healthcare system. Can we take some of that data into the process? Now, I was in the clinic yesterday with my patients, and just thinking back, 100 years ago, the data that was used to take care of a patient was all in the head of a clinician, and it was collected there and synthesized there. Then, over the course of the 20th century, as we developed methodologies, we began providing evidence from basic research all the way through population science in that era of what we call evidence-based medicine. And it was the responsibility, again, of that clinician to read the journal article and synthesize all that data and then try to make the decision for the patient. Now we have an opportunity to take that data and to be much more sophisticated in synthesis and to assist that clinician sitting in the office to curate that data and to synthesize that data from multiple sources, from outside the organization, along with all the data, the real world data that exists within. That's what really the topic of today is. So the VA data ecosystem is extensive, and the first thing that I wanted to mention is that the healthcare system is expansive. It takes care of about 9 million patients a given year. We have an extensive database of about 25 million veterans who use this healthcare system. There's 1,700 points of care throughout the VA. And the data from all of those interactions gets regionalized into 4 regional warehouses that gets rolled up to the corporate data warehouse. The data is extensive. It's the most granular EHR in the world. And it was created, unlike any of the other EHRs that were created as billing platforms. This was created by doctors and some of our nerdy informatics friends for the purposes of clinical care. Because billing, while we do track resource utilization and RVUs, those kinds of things, for management purposes, this system was grassroots founded for the purpose of delivering care. There are 4 regional data warehouses, and everything gets pulled up to the corporate data warehouse. And that's access for both clinical analytics and for research analytics. I want to talk a little bit about the embedded research program we're celebrating 100 years. It's expansive. It covers basic research through all types of population research. And the cooperative studies program is quite old and has covered a couple hundred different trials. The first trial was in 1948, discovered mice treated tuberculosis, and Oxford did that trial in that same year. And that was cited as the 2 first randomized trials. And interestingly enough, it was the same year as the founding of the first cohort study, which was the Framingham Heart study, where the data was analyzed not far from here in some of the punch card computers in the basement of HMS, giving us the first use of computing and logistic regression in population science. So 1948 was a big year. The $1 Million Program was born out of the cooperative studies program, and as was our phenomic engine that Phil will get more about. So this gives you a few of the milestones along our local journey, embedded in sort of the national journey. In 1985, the VA-CAUSAL was standardized across all the veterans in a system called DHCP. The D stands for decentralized, which allowed for some latitude at the local sites for some experimentation, but with national standards. And then eventually that data, as I mentioned, became corporatized in the corporate data warehouse. In the 90s, we established the Epidemiology Center at $1 million a year to understand how we can utilize that data to do epidemiologic studies. And that enterprise in Maverick has grown to annual funding of about $60 million a year, with about 300 employees. We added a trial center in the early 2000s. We had a elaborate biobank, which became the National Biorepository around the same time. It was there that we were invited to participate in the $1 Million Program as we grew the center and the data for all of the phenomics data. And a couple years ago, we hit the $1 million mark for the recruitment. And the special sauce of that is not only the willingness of our veterans to participate, but the richness of the data resource. We've added an informatics course to support the genomic analysis and non-genomic analysis, precision oncology. And then in 2019, the Causal Inference Enterprise vision was bandied about with Miguel and Rachel and others. And at the same time, our phenomic engine called Cypher was also under discussion about how we might make it available to other researchers. And then the pandemic hit, and in both cases, the opportunity to really grow those 2 operations came into being, and there was a real need to understand how the pandemic was impacting our veterans. And there was an early causal project that you'll hear more about, and the Cypher engine was launched. So what are the challenges for doing causal inference in the VA? Research exists within silos, and research itself is siloed from clinical care. And I think what the key here is to break down some of those silos. The expertise is also associated with those research silos. There are hundreds of thousands of data sets and data landlords that control that data, and you have to knock down all the regulatory barriers to get access to all that wonderful data in the system. And then we need the appropriate tools. Now, some of the examples that are going to be presented later today are from the trials program, the cooperative studies program, from the $1 Million Program, the National Genetics Cohort. And one of the communication tools that we do use is the Cypher engine. And all of those you can learn more about. I'm not going to go into much detail about those today, but there are websites for each of those where you can learn more. A little bit about the progression. So from the early discussions and early beginnings in 2019, the program was supported in what's called the CSP 2032, which was the funding authority to fund the methods core and the implementation core, which I'll describe shortly. And then the use cases were developed, and those use cases served a couple of purposes. First was to develop methodologies to utilize the different kinds of data resources, and second was to answer queries. So the overall goal is, as always, to improve the health of veterans, to make research data and real-world data more relevant to patient care, and to put it in the hands of people who need that data. And to do that, we needed to implement state-of-the-art causal inference methodologies throughout the research enterprise. And we needed to improve cross-site and data access across those various resources. And this is a schematic created by Hannah, or created by the team here, to describe some of the work that's being done on this. It embeds a causal inference methodology capability within the data architecture to accomplish several goals, and it accesses data from trials, from the EHR health records, from the biobank, from the omic data, and integrates that data in a system to conduct various types of evaluations of the data, answering different questions, whether it be targeted therapeutics, efficacy, safety, and extend effectiveness of existing treatments. Again, with the goal of implementing better care. And two cores were created. There was a methods core, which was developed to apply causal methods using large-scale data resources, led by Miguel and Barbara in collaboration with Hannah and Kelly Cho, who runs our genomics data core for MVP and Cypher Engine that I mentioned. Then there was an implementation core that supports investigators who want to use these tools throughout the VA research enterprise. These are based at West Haven under Hannah's direction. This is just a quick scan of how target trial emulation methodologies have accelerated since the advent of this core. And it's a small portion of the total studies that use these methodologies, but you can see the meteoric rise of the application. So I'll end by saying today what we're going to hear about is the use cases that were used to answer, as I said, important questions, and to develop methodology using non-genetic observational studies, using the genetic information in the veteran program, using residual data from a CSP trial, and then addressing clinical important relevant clinical questions. So as always, I want to end by reminding us of that important mission. The mission of the VA came from, I think, Lincoln's second most important talk, which was the second inaugural, where he speaks about unity, and that part of that process was carried to the veterans and their families. And these are some of the veterans that participate. Our motto for some of our trials, particularly the Better program, is another way to serve. And we have to remember the overall mission is to improve their health care, right? And reminding us that the VA-CAUSAL is a wonderful place to work, to do research, and to do clinical care, because it's more than just a healthcare system. It is a community of people who each other. The lower right corner are my father, who is in the physician's health study, who's also in the veteran program, and my son, who's also in the veteran program, is wearing my father's captain's bar. So and working at the VA is often a family affair. So I'm looking forward to an exciting discussion today, highlighting the importance of this particular collaboration, and to further highlight the importance of these kinds of academic VA collaborations, which are really essential to it. and also